The broadcast is now starting. All attendees are in listen-only mode.
Good evening, and thank you for joining us. I'm Deborah Livingston, and I'm the Development Director with the Mayfield Education and Research Foundation. Welcome to our next installment of Brain Talks, our webinar series created to improve your brain health. We're picking up this evening after February's webinar, where we learned about which headaches and other symptoms not to ignore. Tonight, we are joined by Dr. Andrew Ringer here at Mayfield Brain and Spine. Dr. Ringer will help us learn more about the heart and brain connection. Thank you, Dr. Ringer, for joining us this evening. Before we start, let's take a moment to ensure that everyone is ready and familiar with the webinar control panel, which is located on the right side of your screen. First, you can minimize this panel by clicking on the orange arrow button in the upper left-hand corner. You can expand the panel by clicking the same button again. Second, you have the ability to submit questions using the question pane located on the control panel. If it's not open already, just click that question bar to expand it, and you will see where you can type and submit questions to us at any time, and we will answer them at the end of the presentation. Finally, this webinar is being recorded and will post online at mayfieldfoundation.org for later reference. Now let's get started. We are very honored to have Dr. Andrew Ringer join us. Dr. Ringer is the chairman of Mayfield Brain and Spine and also a board member of our Mayfield Foundation. Dr. Ringer specializes in endovascular surgery. In 2019, he was honored as one of Cincinnati Business Courier's healthcare heroes and is consistently listed as one of the best doctors in the region by Cincinnati Magazine. Thank you for being here, Dr. Ringer. You may now begin your presentation.
Thank you, Deb. I appreciate the introduction and welcome everybody for our talk tonight. We wanted to talk a little bit about the brain-heart connection, and really the main purpose of this discussion then is to talk a little bit about ways that the blood supply, the oxygenated blood supplied by the heart to the brain, can affect your health overall, and in particular, in certain ways, it can affect the effects of aging, such as memory and cognition, balance, and the things of that nature. So when it comes to brain health, there are a number of different areas that we want to discuss and with regards to the vascular supply. So there can be problems related to the amount of blood flow that comes to the brain. We call that the vascular sufficiency, or if it's too low, vascular insufficiency. There are what are often referred to as mini strokes, or TIAs, which stands for Transient Ischemic Attack. And that is much like what chest pain might be to a heart attack. It's sort of the warning shot across the bow that something bigger may come. And that something bigger is number 3, which is a stroke, which can be a cataclysmic event and catastrophic to some patients, depending on the location and size and whether or not that patient is able to recover. But a more insidious source of that same kind of problem that can arise related to the vascular health to your brain can result in cognitive decline that we refer to as vascular dementia. This is different than Alzheimer's and other types of dementia, which are just degenerative, and is related instead to gradual loss of viable brain tissue due to poor blood supply, largely involving the small, tiny arteries penetrating into the deep parts of the brain. So why does vascular health relate to your memory and cognition? Well, there are certain parts of the brain that are really important towards memory and learning, and they incorporate different things that include everything from smell and emotional control and things of that nature to higher parts of the brain that store those memories for us and allow us to retrieve them later. And these include parts of the brain in the mesial temporal lobe, known as the hippocampus and the amygdala. And these are also very important parts of very rudimentary brain functions, which is why things like smell or emotional responses can generate such bright and significant memories for us. You know, everyone knows that that smell of chocolate chip cookie dough cooking or something might remind you of your grandmother's kitchen. Well, this is why, because those deep-rooted reflexes are intricately linked to our memory and higher cognitive function. The amygdala itself is responsible for some of that emotional component. It's sort of a fight or flight motivation type of portion of the brain that stimulates those memories as well. So this is part of how we are wired to learn in a way that protects us from some of the threats to our health and our safety. These deeper parts of the brain then share a very important connection to higher, more conscious parts of the brain, such as the prefrontal cortex, which works on short-term memory and is intricately linked to the other parts of the brain that we have discussed, including the thalamus and the fornix. So all of these parts of the brain, deep inside the brain, are responsible for maintaining memory, learning, and cognitive function. So long-term memory can be kind of divided into a few different levels of function. There's episodic memory, where you remember certain specific events that might be something like your graduation day, your wedding day, or even just where you left your car keys that afternoon, to semantic memory, where you understand the meaning of words and objects and language, and procedural, such as remembering how to tie your shoes, how to ride a bike, how to ride roller skates, all these things that you learn eventually but become kind of habitual for you once you do them over and over and over again. But all of these tissues do rely to some degree or another on delivery of oxygenated blood to those parts of the brain, and this is where the heart-brain, and you could say the heart, lung, and brain connection really comes into play, because these brain tissues require certain levels of nutrients and oxygen delivery to maintain their viability and their growth. Anything that interferes with that blood flow could interfere with the function of these parts of the brain and result in deterioration in cognitive functioning and memory. So among those things that can interfere with the blood supply to our brain, there's a whole list of them that you see here on your screen. It includes atherosclerosis, or sometimes called hardening of the arteries, high cholesterol levels or high blood pressure, diabetes with high blood sugar, heart problems such as heart failure or poor heart function that doesn't perfuse the brain adequately. There are things that we can do to ourselves, like smoking and alcohol use, or things that you can't control, like your age, and to some degree, sleep apnea or lung disease like COPD, chronic obstructive pulmonary disease, that results in low oxygen levels with delivery to the brain. So all of these things can combine to create that same effect of essentially starving the brain of appropriate blood flow. Now, let's go look at some of those types of vascular disorders that we discussed previously. Vascular insufficiency is a chronic, gradual process that results as a gradual decrease in blood flow to areas of the brain, usually involving the very small blood vessels penetrating the deep parts of the brain. In mild cases, this might result in decreased ability to maintain attention, kind of slow thought processing, and slow processing of new information. But in more severe cases, can result in loss of attention to detail, problems with balance and falls, to significant memory problems that can affect your safety and your ability to maintain employment or daily chores, things of that nature that can be quite problematic. In these cases, with this type of vascular insufficiency resulting in cognitive decline, general functions are still preserved. You can still walk, you can still dress yourself, you can still set the table, you can do all these things, so it doesn't have quite the same effect that other types of vascular disorders to the brain might have, and tends to be a little bit more gradual in onset. Conversely, a transient ischemic attack, or TIA, sometimes called a mini stroke, looks to all the world like a stroke, but just is very brief. In this situation, you may have a blood clot that breaks free from either a cholesterol plaque or from a heart problem like atrial fibrillation, a heart rhythm problem, or heart valve problem that clogs up a brain artery temporarily, starving that area of the brain for blood flow, so that you have the sudden onset of fairly noticeable neurologic functions, loss of neurologic functions, such as weakness, loss of vision, loss of speech, for example. But then as that blood clot dissolves spontaneously, the blood flow is restored before there's permanent damage to the brain, and those functions return. Hence the name transient ischemic attack. This, however, should be a warning to you about the bigger problems that can come downstream, because not in all cases will that clot dissolve on its own. And if it doesn't, then you're looking at a more permanent problem if there's not blood restored. So a transient ischemic attack is basically a stroke that reverses itself. And by our definition, that is within 24 hours, although most do so within about 15 or 20 minutes. So again, transient ischemic attacks are a brief interruption of blood flow through a vessel with sudden onset of symptoms. These would be stroke-like symptoms, such as slurring of the speech, trouble with language function, a droopiness on one side of the face or the other, clumsy or weakness in the hands, or loss of vision to one side or in one eye. Sometimes it causes people to look a bit confused or behave as if they're a bit confused because they don't quite understand what's going on, and maybe they don't even recognize the symptoms in themselves. But repeated TIAs usually do result in some, if they keep happening over and over again, this usually means that there's some degree of small stroke occurring, and that will eventually add up. It's like death of 1,000 cuts. You get a tiny little bit of loss of function each time this happens. The key feature about a TIA is that it does resolve quickly. Again, the medical definition is within 24 hours, but the vast majority do so within minutes. The problem is that you can't ignore that. The simple fact that it got better on its own, you can't just simply wipe your brow and say, whew, got away with one there. This, again, is a warning sign. This is a shot across the bow to tell you that the big one could be coming. Many people who present with strokes first present with TIAs, and conversely, about 30% of patients who have a TIA will go on to have a true major stroke within the first few months, about 20% even within the first 2 weeks. So this is an important warning sign that you need to find help, you need to get something fixed, you need to find the source and try to prevent that major stroke from occurring. Again, once symptoms resolve, daily living skills are typically preserved with this kind of a problem. Now, ischemic stroke is TIA's big brother. This is where that blockage does not reverse itself and where blood flow is not restored, at least not in a timely fashion, and can result with some of the same symptoms that we talked about. These can be loss of language, loss of strength, loss of vision. Again, it can result, depending on the depending on the location of where the stroke occurs, it may be expressed differently depending on what functions that part of the brain controls. And as a result, you can see a whole slew of different symptoms. But the important point here is that if we don't do something to unblock that artery and get it done fairly quickly, the damage is permanent. There can be some recovery after stroke, but it is slow, it is gradual, it is typically incomplete. So your best odds are to try to reverse that stroke by getting emergency care as quickly as you can. Depending on the severity and location of the stroke, daily living skills might be retained, or they could be relearned with therapy, but it really depends on where in the brain the stroke occurs and how severe it is. And in some cases, patients remain totally dependent or even have a life-threatening stroke. Now, vascular dementia is a little different than TIAs and strokes, where what happens is effectively it's a stroke, but in a microscopic blood vessel, not one of those big arteries that we saw on the diagrams earlier for TIA and stroke. In this case, through the effects of chronic high blood pressure or diabetes or smoking or something of that nature, you'll see these tiny little blood vessels at the deep parts of the brain closing off one by one with tiny little itty-bitty spots developing in the brain that we can see on MRI, little itty-bitty tiny strokes, essentially. Now, as a result, you don't see a big event like you do with TIA or stroke. You don't have a recognizable instantaneous change that you or a loved one might recognize and say, hey, we need to do something about this. Each change is just the most subtle little injury to the brain that it takes many of them to add up and become noticeable. And as a result, this is a typically gradually recognized process that develops over months or years of this type of injury occurring. It can result from chronic progressive small vessel disease, the result of multiple small strokes, or it can result from one large stroke, in which case there is a recognizable event, but recovery is significantly incomplete. So this is kind of what it looks like. So you can see vascular dementia forming from a number of different mechanisms, where you see on the far left scan here is an MRI that we call a flare type of imaging, where the little white spots are tiny areas that have been somehow injured or compromised by reduced blood flow over the years. Sometimes they coalesce into one larger piece where you get a little bit of a hole in the brain, like you see in the middle spot that we call lacunes, little lakes, or on other types of MRI imaging that are very sensitive to small amounts of iron, typically dropped in from a little bit of blood. We can see these little tiny hemorrhages in the brain that accumulate over time. And all of these can accumulate as a result of multiple small injuries to result in some significant disability. So in the case of the patient who has vascular dementia, what we notice first is their cognitive impairment, not loss of vision, not loss of speech, not paralysis of an arm or leg or droopiness in the face. It is rather inattention to detail, trouble doing problem solving, or making poor judgment, poor decisions in judgment. This is the kind of thing that you start to notice over time. And occasionally we can also see that memory is affected as well. So for some patients, behavior changes and personality changes can be seen. It might be sort of an apathy, or in some cases they become more irritable or angry. Hard to know if that's the direct effect of the microbleeds or microstrokes that are occurring, or if it is rather a response to the loss of that function that they've been so used to having for so many years. But when you notice a loved one having new problems with problem solving or memory, and they're having behavior changes, this is one of the things to worry about that could be occurring. So one of the big distinctions, however, is normal daily function again is preserved. You can still dress yourself, you can still go to the table, you can still set the table, you can still tie your shoes. All these kinds of things still happen, but it's the higher cognitive functions that are more completely affected. So all of these things, all of these vascular sources, whether it's one major stroke, multiple TIAs, vascular insufficiency, or dementia, they can all lead to dementia if left untreated. Dementia, by the medical definition, simply is a cognitive impairment related to brain injury or degeneration. So any of these things can result in that. It's just a different time course and pattern of symptom onset that differentiates these issues. And they all typically have some of the same risk factors. So understanding how to prevent them really helps you prevent all of these things. So one of the first things we do is we want to start with the big stuff. Start with how to recognize a stroke. This is one of the most important things, because the treatment of stroke has evolved and improved so dramatically over the time of even just my career that it becomes ultimately very important to be able to recognize a stroke, because we went from barely having anything to do to treat a stroke to being able to reverse even some of the most severe strokes almost completely in some cases. So what we like to tell people, an easy acronym to remember, is FAST, which stands for face, arms, speech, time to call 911. If you recognize a loved one who has droopiness on one side of the face or the other, they might be having a stroke. If you ask them to elevate their arms, but only one arm seems to come up and the other drifts off to the side or doesn't raise completely, they may be having a stroke. If you ask them to speech and their speech is badly slurred or is coming out like it sounds like Greek and they don't speak Greek, then they may be having a stroke. And if you notice any of these things, then it's time to call 911. Some like to use the acronym BFAST, where you include balance and eye movement to see if they are having strokes in other parts of the brain, but the concept is still the same. To recognize the asymmetry of these functions and recognize that it's an emergency and call 911 immediately. Now, how do we do that? What happens if you do bring in a loved one with a stroke, and what are we going to do for them? Well, it depends a little bit on how big is the stroke and how early do we see them. We recognize, for example, and have known this for many years, that if we get a patient within 3 to 4.5 hours, or at least within 4.5 hours of the onset of their stroke symptoms, that in some cases we can use a blood clot dissolving medication called TPA, that stands for tissue type plasminogen activator. It turns on an element in your blood that is designed to break down blood clots. And if we give that drug fast enough, in at least 30-some% of cases, it may be able to significantly reduce the damage from the stroke by reversing that blockage in the artery and restoring blood flow. So as that blood clot breaks down, blood flow can be restored. We can, in other cases, we can try to prevent blood clots from forming in the first place by opening up blockages in the arteries that form them. One of the common locations where this may occur is the carotid arteries in your neck. You can feel the pulse of the carotids in the front of your neck on either side of your throat. And these are major arteries that feed the brain, where we have recognized that cholesterol plaque tends to build up in these arteries and tends to be a high risk factor for stroke. It turns out, however, that we can do surgery to clean out that cholesterol plaque, or we can cover it up with a stent. And scientific clinical trials have shown us that that significantly reduces the risk of a blood clot forming in the artery and subsequently causing a stroke. So if you are found to have carotid artery stenosis, you should talk to your doctor about seeing a vascular specialist such as a neurosurgeon who can tell you whether or not that treatment is appropriate for you. Now, we talked about how in the case of an acute stroke, the TPA may be given through an IV to circulate through your blood flow and turn on your plasminogen that will disintegrate the blood clots in the arteries in some cases. And if that happens quickly enough, it dissolves the blood clot and can restore blood flow. In some other cases, where much larger arteries are blocked by these blood clots, the TPA may not be enough. It may be just like kind of spitting into the ocean. And instead, what we do is an interventional or invasive procedure, what we call endovascular, which means inside the artery procedure, where we go inside the artery, find the clot, and use a tool or device that either sucks the clot out or grabs a hold of it like a fishing net and pulls it out in order to open up those blood clots. Other well-done clinical scientific studies have shown that in patients who are having very big strokes, that this kind of procedure to go in and remove the blood clot mechanically, what we call mechanical thrombectomy, is actually more effective than even the TPA and can reverse stroke effects in a large number of patients. But as you can see, the stroke that we choose, rather the stroke treatment that we choose, depends on the type of stroke that's occurring. Is it a small blood vessel that's being blocked off or a very large one? TPA may be very effective at dissolving blood clots in smaller arteries and reversing the stroke. You don't need to have an invasive procedure. But when these strokes are becoming more significant and a larger branch artery is occluded, that may not be sufficient, and we can actually do a better job by going in and opening them up. So some of those large blood vessels that may be occluded are branches of what we call the middle cerebral artery that goes around to either side of the brain, the anterior cerebral artery that comes up from each carotid towards the front and the middle of the brain, the internal carotid arteries, those same ones we talked about in your neck, but as they continue on up inside your head, they pierce the skull about the level of your cheekbone, and they can be blocked up inside the head there as well. Or arteries that feed the back part of the brain, called the basilar artery, and the posterior cerebral arteries. Each of these arteries feeds a different part of the brain, and therefore the stroke symptoms that occurs with a blockage in either one of them will be different depending on that location. So what we do in those cases where a large artery is occluded is we can use a device like the one you see here. This is what we call a Stent Retriever, or Stent Retriever as we use for shorthand, where we go through the inside of the artery using X-ray to see where we're going, pass a small tube or catheter through the clot, deploy that thing that looks like a stent, but it's hooked onto a wire, and use it to pull the blood clot out and restore blood flow into the artery. So this is a revolutionary type of procedure that's only been proven and FDA approved as primary treatment for a few years, maybe 5 or 7 years, but is, again, one of the big changes that's occurred in stroke care. So as a result, we now can, in those initial trials, found that using those stent retrievers or a similar device, a suction type of device, within 6 hours of the onset of symptoms can significantly reduce the burden of stroke for most patients and even cure the stroke in many patients. But it doesn't stop there. The science has gotten even more exciting subsequently as we added to these procedures and tools and medications the technology that we have in imaging. There are new ways of imaging the brain that can not only show us the anatomic structure of the brain, but even show us and measure the amount of blood flow that brain is getting. And as a result, we can use this type of imaging, we call it perfusion imaging. We can use it to look at the brain during a patient's stroke to say, well, I know it's been more than 6 hours, but Is the brain still alive? Is there still living brain tissue that might go on to have a stroke but could survive and recover if we restore the blood flow? And in 2 trials, 2 scientific clinical studies, it was shown that, as a matter of fact, yes, you can. And if you find a patient who's having a stroke, but that the permanent damage is small and the potential for permanent damage is very large, doing that same procedure with the stent retriever or the suction device to remove the blood clot, that mechanical thrombectomy procedure, can reverse the effects of these strokes, and these patients can survive and recover from those strokes, even if we treat them up to 16 or 24 hours after the onset of their stroke. That is remarkable. That kind of treatment opportunity has not been available until the past few years. And we here at Mayfield are very proud to have been part of those trials that showed that both those devices work and that this imaging works, and to provide that kind of stroke care to the greater Cincinnati community. So the lesson here is, just because you think somebody's having a stroke doesn't mean you have to give up, even if you don't know exactly when it happened. Whenever you find the stroke, treat it like an emergency right away. If the FAST looks abnormal on your loved one, bring them to the emergency room immediately. Let us sort it out. We will figure out what there is to do that can potentially help that patient, even if you don't know when those stroke symptoms started. We can try to figure it out. But as you always hear, an ounce of prevention is worth a pound of cure. So why not just avoid the stroke in the first place? And why not avoid that progression to dementia that can happen with the vascular insufficiency and everything else? What can I do to help reduce my risk of not only having a stroke, but maybe of having some of that cognitive decline that comes with aging and the vascular dementia? Well, the first thing to do is to control your risk factors. Look for the things that can impair blood flow to the brain and fix them, get rid of them. So quit smoking. You've heard it a million times. Smoking is bad for you. It not only causes cancer and heart disease, but it puts you at risk for strokes. But it also can cause the slower type of damage like that vascular insufficiency or vascular dementia, and increases the likelihood of having cognitive decline with aging. And all of that, along with your yellow teeth and smelly breath, is just $3 or $4 a pack. Congratulations. If that's how you want to spend your money, I would not recommend it. The other is to control your blood pressure. Blood pressure or high blood pressure is known as the silent killer. It does not typically cause any symptoms. You don't feel it. You can feel perfectly fine, and your blood pressure might be totally out of control. You won't know until you get it checked. So please have your blood pressure checked. See your physician, monitor it regularly. If it is getting high, then it should be treated. What we like to see is the top number, known as the systolic blood pressure, to be 140 or lower, and the bottom number to be 90 or lower. Newer guidelines even suggest we'd like to see it 130 over 80 or lower. But if you're consistently above that range, you might need medications to treat it. If it's there once in a while, that doesn't usually count. Typically, we consider it high blood pressure if it's high on 3 consecutive measurements. The other is to control your alcohol intake. A little bit of alcohol is not bad for you. If you have 1, maybe 2 drinks a day, then that's fine. And that doesn't mean you go without alcohol all week and then you have 14 drinks on Saturday. That's not what that means. It literally means 1 or 2 drinks a day. Those 1 to 2 drinks a day might even have some mild health benefits, but at the very least, it does not seem to be a problem. But it also is important to understand what is a drink. A drink is 12 ounces of beer. That means the regular kind of beer, like the 5%, 5.5% alcohol or less. It is 5 ounces of wine. That means there are 5 glasses of wine in a bottle, not 4. So if you and your loved one are sharing a bottle, you're each having 2.5 glasses. And 1.5 ounces of 80 proof liquor. That doesn't mean the really high premium stuff that's 100 or 110 proof. It means 80 proof liquor, 1.5 ounces. So that's what counts as a drink. So if you're giving yourself a strong pour, you might want to count it as 1.5 or 2. The other is to modify your diet. Pay attention to what you eat. The old adage, you are what you eat, still is true. And a lot of research has gone into nutrition and identifying the types of diets that are good for us. And there are a lot of different healthy ways of eating, but one that is specifically looked at cognitive function and avoiding cognitive decline is what's known as the MIND diet. It's sort of a combination of the Mediterranean style of eating and what's known as the DASH diet. DASH was a diet put together to help control heart disease and blood pressure. And the goal is to identify, if you really boil it down to its simplest level, identify categories of food that are really good for your cognitive function and your brain health, that also happen to be good for your vascular health, so they help you to avoid heart attacks and strokes as well. And they include things like green leafy vegetables, non-starchy vegetables, so in other words, not the potatoes and things, berries, nuts, olive oil, whole grains, fish, beans, poultry, and a small amount of wine. If your goal is to eat 10 of those brain-friendly foods a day, and then avoid or limit your exposure to the unhealthy items that can be hard on your brain health, such as butter or margarine, cheese, red meat, fried foods, sweets, and pastries. Now, the last bit, everybody understands that, the fried foods, sweets, and pastries. But really, cheese and red meat? Well, it has to do with the type of fat in these foods and the fat content in them that makes them less healthy than leaner sources of protein, such as the beans, the poultry, and the fish. So look at this list, try to remember it. We'll send this talk out to everybody so you can have the same kind of list, and think about how to maximize your intake of the healthy items and try to minimize your exposure to some of the unhealthy items. And one of the last pieces that's really important is getting regular exercise. Physical activity is really good for your cognitive health. Everybody understands how it helps you to control your body weight, how it helps to build muscle tone, how it helps to protect your heart and protect you from heart attack. But did you know that you would actually also score higher on intelligence tests if you get regular exercise? One very good study, the Carotid study, was a long-term observational study, looked at 2,700 healthy people who didn't have other significant health problems, and followed them for about 25 years. They checked their level of fitness at the start of the study, and checked them again for up to 20 years to see who maintained good physical fitness and who didn't, and then put them through a cognitive test. And what they found was those patients who were physically fit scored 10% higher on the test than the patients who were not as fit. Now, just, it may sound like a small margin, but just understand that a 25 or 30% difference on the test might be the difference between a highly functioning CEO of a big business and somebody who's barely able to take care of themselves. So that 10% is a pretty significant difference. So again, we advocate for regular exercise. So among all the different things that you can do to help avoid stroke and avoid vascular sources of cognitive decline or dementia, memory loss, and the things of that nature, look at this list. Control your blood pressure, control your blood cholesterol. If you have diabetes, make sure it's treated. Quit or avoid smoking. Try to maintain an ideal body weight through diet and exercise, and of course that includes getting regular exercise. And finally, be aware of heart conditions that can lead to vascular problems, like that heart rhythm problem I discussed earlier, or heart valve problems, the rhythm problem most commonly known as atrial fibrillation. So these are some really good take-home points that you can remember to help reduce your stroke risk and help avoid some of those problems that can come from it. So I know that was a whirlwind of information. We didn't take a whole lot of time to get into some of the details, but if there are questions, I'd be happy to answer them. Keep in mind that at Mayfield Clinic and Mayfield Brain and Spine, we're very big advocates for a healthy lifestyle, things that can help you to avoid some of these disease processes. There's lots of information on ways to do it, as well as lots of information on ways that we treat stroke and some of the effects of these things on our website at mayfieldclinic.com. And thanks again to Murph for supporting this lecture series. We think it's a great service to our public. And we, as part of the mission for Mayfield and for Murph, to help educate people about their health and help them to maintain a healthy lifestyle. So again, if you have any questions, I'd be happy to take them now.
Thank you so much, Dr. Ringer. That was wonderful. I personally learned a great deal. So we do have a number of questions. Brain aneurysm survivors are supposed to get their blood pressure at 140/90 or below. Is that resting blood pressure? Is it okay for their blood pressure to go up during activity?
That's a great question. So the answer is yes, that is a resting blood pressure, and that's also true for heart disease and other conditions as well. Now, keep in mind, however, that for most people who have a normal resting blood pressure, that during activity, the top number might go up. It doesn't necessarily, but it might go up because of the increased cardiac output that that is demanded for the muscle activity, but the bottom number usually doesn't. So you should not see that bottom number going up. That's really what happens in between the heartbeats. And that in most individuals during exercise might even go down a little bit because the blood vessels are dilating to accommodate the blood flow to the muscles that you're using. So the answer is yes, we can allow for the top number to go up a bit during physical exertion. That's not necessarily a problem, but the bottom number really shouldn't change as much.
Okay. Are there types of exercises that would not be safe for a brain aneurysm survivor to engage in? Does the type of hardware in their brain make any difference regarding this, such as clips, coils, stents?
Yeah, so I'll take the last part of that question first. And the answer is no, not really, with the possible caveat that for some patients who have the stents or the coils placed, which are on the inside of the arteries, for some of those patients, we put you on extra blood thinners for a period of time while that's healing in place. And for obvious reasons, things like contact sports and the like are probably not a good idea while you're on blood thinners. You're going to bruise a lot. So I always tell my patients, no rugby while you're on your Plavix. Now, for the surgical clips, the answer is no. And in the long run, even for the inside the artery devices, the answer is no. It really should not. They will not affect the type of activity that you're allowed to do. What we do find, however, while it's not necessarily an unsafe practice to do a heavy, strenuous lifting or things of that nature, some of our patients after a brain aneurysm repair or after hemorrhage from an aneurysm that they have survived, that type of heavy lifting or straining that kind of turns the power lifter's faces blue, that can stimulate headaches. So it's not very comfortable. So rather than that kind of steady state exercise, the kind you might get by a good walk or run or ride on the exercise bike, something like that may be better and more easily tolerated.
Okay, great. Is a brain aneurysm survivor at higher risk than the general population to develop aneurysms in other parts of their body, such as an aortic aneurysm?
So another great question, and the answer is, if you look at the whole population of patients with brain aneurysms, the answer is yes. But that doesn't necessarily apply to each individual with a brain aneurysm, and the reason for that is multifactorial. So in the one case, there's a minority of our patients who we believe have what we call familial risk factors for aneurysms. That means that they may have a genetic predisposition to forming aneurysms. And that might include some genetic disorders, such as, for example, polycystic kidney disease or certain types of vascular collagen disorders that are kind of rare. But those patients may be at greater risk of forming aneurysms elsewhere in their body. The bit about the aortic aneurysms is interesting because there is an association between the two. However, there's also a strong link between the risk factors for them: high blood pressure, smoking, and cholesterol disease. So many patients who have one are at risk for having the other because of their risk factors. So the aneurysm itself doesn't necessarily cause you to have another aneurysm elsewhere, but the risk factors do. So again, the good news of that is that's something you can control. So if you've gone about your life and suddenly found out you have an aortic aneurysm or a brain aneurysm, and your doctor told you need to quit smoking and get your blood pressure under control, well, you better do it, because that's something you can do to help avoid that second event.
Okay, great. Being a survivor of a ruptured brain aneurysm, will I get dementia?
Yeah, and so that won't give you dementia. Some patients, after recovering from their initial hemorrhage from the aneurysm, find that their cognition doesn't recover all the way. Keep in mind that higher brain functions like cognitive function and memory and things like that are such complex neurologic functions that they are very susceptible to injury, very slow to recover, and probably the least likely to recover fully. So some patients will have that as an acute event and then incomplete recovery. But it doesn't necessarily lead to subsequent degenerative forms of dementia. So in other words, it doesn't mean that you're likely to get more likely than the rest of the population to get worse in the future. Does that make sense? So you might have some patients, some survivors of brain aneurysm rupture will have some cognitive difficulties that are kind of permanent and a result of that injury, but it doesn't mean that those survivors are going to get new forms of dementia in the future.
Okay. I'm a 14-year post-allo transplant patient. My cognitive processing is significantly lower. Is this due to transplant process, chemo, or combination? Also, I was sepsis for a short period of time with the first 100 days of transplant. Would I be a candidate for perfusion MRI?
So first of all, congratulations on your recovery from what must have been a really big ordeal. I'm really glad to hear you've done so well. That's fantastic. I would estimate, it's hard for me to know because we haven't met and I haven't looked at any imaging studies and I don't know exactly what immunosuppression protocol you were taking for your transplant, but those medications can be hard on a body. And I would say it's probably more likely that the transplant process and the medications or drugs that you're required to take contributed to some of the cognitive decline. And that is not necessarily a blood flow related process. So my guess is if we did a perfusion study on you, it wouldn't really show anything. We don't typically recommend perfusion studies for people who are simply for cognitive functioning. And the reason is twofold. Number one, the amount of blood flow decrease that is required to show up as significant on that imaging study is more akin to the type that might put you at risk for stroke, like a big major event, not the subtle changes that occur with vascular dementia. So we may not even see the abnormality on that study. And the other is there's really not a, other than risk factor reduction, there's not a direct treatment that we can do to help augment that blood flow that would reverse that kind of cognitive decline. So, I would not recommend a perfusion study for you. I don't think that that's likely to be helpful, but you certainly can talk to your doctor to help review your potential risk factors for any further cognitive decline and try to avoid it.
Okay, great. Can you describe the anatomy of an artery, i.e., what material is it made up of? What is actually occurring to the artery when it becomes too hard, too elastic, or weak?
Yeah, so it's a high-grade, military-grade plastic full of another liner. No, I'm kidding. It is. That's a great question. There are several different layers to a blood vessel, and keep in mind that blood vessels in some parts of our body are a little bit different than others. But in general, if you're looking at, for example, the large arteries, the carotid arteries or others leading up to the brain, there are three main layers, more than that with tissue types, but there's the inside that we call the intima, that I refer to often as the wallpaper on the inside of the wall. Excuse me, there is the kind of middle or muscular layer, which is responsible for helping the artery to remain turgid and it helps control the size of the artery based on blood flow demand so that you can raise or decrease the amount of blood flow going to that particular tissue. And then on the outside is what we call the adventitia, or the coating or the shingles on the wall on the outside. This comes into play sometimes when we see certain types of injuries that we call a dissection, where the layers may kind of pull apart. And sometimes what happens is the wallpaper on the inside pulls away from the rest and flaps across the inside, and that can actually be a cause of stroke. We see that on occasion, sometimes after trauma, or in young adults who have what we call a collagen vascular disorder that puts them at risk for having that happen. I hope that answers your question.
Great. What are the things that can impact the health of an artery, i.e., can diet, exercise, drugs, genetics affect your arteries?
Absolutely. So all the stuff we were just talking about, these risk factors that we were reviewing as risk factors for stroke, that the reason those patients with those risk factors have a stroke is because of the injury to the wall of the arteries. So that intima can become damaged, nicked or torn or what have you, when their blood pressure is very high, or when the artery wall is weakened through smoking or diabetes. As a result, then that makes it easy for cholesterol to deposit into those nicks or injuries in the wall of the artery. In particular, if you have high cholesterol, it's more likely to happen. And then that kind of builds up like rust in the pipes. When that happens, that forms a surface and a flow pattern that is conducive or favorable to forming blood clots. If those blood clots form in the artery and close it off, or they break free and float downstream, they can cause a stroke or a heart attack depending on what the artery is feeding. So all of the things that we talked about today, all the risk factors we talked about avoiding, all the positive and healthy things we talked about doing are for the purpose of maintaining the health of the wall of your arteries.
Okay. I'm an aneurysmal SAH survivor. Per the radiologist report, I have evidence of microhemorrhages. Could that be related to the aneurysm rupture, or is that something separate? I'm young and don't have risk factors for stroke.
So in that situation, that last part of your comment, following your question, probably tells me the most. That probably means that some of these microhemorrhages occurred during the time of your aneurysm hemorrhage. There can be an event after an aneurysm ruptures that we call vasospasm. That's when those muscles in the middle of the walls of the arteries that I told you about kind of go into spasm because they're irritated from the blood and can constrict the arteries down. That might restrict blood flow and cause little small strokes to occur in the brain. Sometimes not so small, sometimes even big life-threatening ones to occur in patients in the couple of weeks after their aneurysm has bled. MRI can be very, very sensitive to small amounts of iron from small hemorrhages for years to come after that. So the fact that we see them now doesn't necessarily mean that they happened recently. They could have happened quite some time ago. And if you don't have other risk factors and you're young and otherwise healthy, the likelihood is that it happened during the time of your aneurysm hemorrhage. But I would be very careful to watch your risk factors and make sure that some of the silent ones like blood pressure really are under good control.
Okay, great. Is it good prevention to take baby aspirin or Prevagen?
So Prevagen really has not been shown. Well, I'll leave that one till later. So the baby aspirin, that one, we've kind of been back and forth on that. There's been very large population-based studies that have gone multiple different directions. So many years ago, it was felt that aspirin was probably only good for people who had already had a stroke or a heart attack. Then we decided, well, no, maybe it's actually good for preventing them in patients who have some risk factors. We even got to the point that we thought that it might be sort of the great wonder drug to help avoid many problems of health and beyond just risk factors for stroke and heart attack, and that the most healthy people in the general population could even take a baby aspirin. But another big population study done subsequent to that showed that in the absence of risk factors, the risk reduction you get with aspirin is so low that it actually is outweighed by the risk of having a bleeding problem. So if you don't have high blood pressure, diabetes, high cholesterol, or a family history of heart attack or stroke, and you don't smoke, then you might not have any benefit from taking a baby aspirin. In fact, you might just make it more likely you'll have some bleeding problem in the future than you would avoid an event. So the current recommendation is to only use baby aspirin for those patients who have risk factors or prior symptoms to suggest a risk.
Great. I think we have just one more question. How many minutes per week if exercise are considered regular exercise?
Great question. So the goal is to get about 30 minutes of physical activity a day, defined as the kind that makes it hard for you to carry on a conversation without stopping for a breath. So if you are, for example, going on a fitness walk with your friend and you can carry on a normal conversation without breaking your sentence down at all to catch a breath or anything, then that doesn't count. But if you're walking along and you have to stop kind of in between your sentences and take a breath and pause like I just did there, that's kind of the metric for the kind of physical activity you want to have. And the minimum is that level of exertion for a minimum of 30 minutes a day, ideally. For the really big go-getters out there, the really serious athletes, research has suggested that more than 5 or 6 hours of high strenuous activity you kind of lose the benefit after that. So between 30 minutes and 1 hour a day of moderate to high exertion exercise is the recommendation.
Great. Thank you so much. Okay, I think there's any other, I think we're all set. Great. Thank you, Dr. Ringer. I think that'll wrap up the question and answer period. Again, this webinar has been recorded and will post on our website shortly. We hope you enjoyed tonight's presentation. If you enjoyed this evening's presentation, please register for our next program on April 27th, where we will learn from Dr. Vince DiNapoli. Dr. DiNapoli will provide an overview on brain tumor types and the latest treatments. You may register for Brain Talks program at any time and view all of our presentations on our website, mayfieldfoundation.org. And for more information about the Spine Talks, Brain Talks, or the work of the Mayfield Foundation, please visit mayfieldfoundation.org. I'd like to thank everyone again for joining us this evening. Thank you again, Dr. Ringer, and please have a nice evening. Enjoy this weather.